Revi, revolutionizing the treatment of urge urinary incontinence. We are pleased to be joined tonight by esteemed experts in the field of urology and urogynecology, Doctors Roger Dmochowski and Cindy Amundsen, who will share their firsthand insights and experience with Revi. A couple of housekeeping items before we get started. The webinar will be recorded, and a recording will be made available after the presentation is complete. In an effort to keep our webinar timely, we have muted all participants. We encourage you to submit your questions through the Q&A function towards the bottom of the screen. We'll monitor these questions that come in, and we'll answer what we can if there is time remaining at the end of the webinar. Without further ado, we'll start this evening's presentation with an introduction from Dan Lemaitre, Chairman and CEO of Blue Wind Medical. Dan, take it away.
Okay, thanks, Amy. Actually, you did all of that I wanted to do. I wanted to just greet everybody, tell them welcome to this webinar, and really not take any time from our faculty who are going to run through some materials that we hope you will find interesting as it relates to a new therapy to treat urinary urge incontinence. So Roger Dmochowski is a professor of urology and surgery at Vanderbilt, and Cindy Amundsen is a professor of obstetrics and gynecology at Duke University. These are two key opinion leaders. An awful lot of people value what they have to say, and I'm not going to take another minute of time and turn it over to, I believe, Roger, you're going to start this morning or this evening.
Thank you, Dan. Good evening, everyone. Good evening, good afternoon, whatever time zone you're on. Next slide, please. It's a great pleasure for me to share this podium with Cindy Amundsen. Cindy and I was thinking about this today. I've known each other for probably 30 years, and Cindy is also married to a very dear friend of mine who is one of the fathers of urologic reconstruction, George Webster. And so I just want to toot Cindy's horn a bit. She is an international leader in the conditions that involve women's health, one of which obviously is overactive bladder and urinary incontinence. And Cindy's going to be amplifying a lot of the points in the presentation tonight. So Cindy, welcome. It's great to have you.
Thank you. Nice to be here.
Next slide, please. So let's talk a little bit about the condition that we're dealing with tonight, and that's essentially urinary incontinence and how patients manage this. And we all know that a lot of women really manage themselves by what is artfully called watchful waiting. Well, which means that basically they're waiting for something bigger, better, and perhaps best for them as a match. And there's a variety of associated statistics related to that watchful waiting, including very low adherence rate to oral drugs, unfortunately long-term, with long and significant discontinuation rates, especially after 6 months, and very little uptick in third line, what we traditionally, based upon guidelines, taxonomies, have described as third-line therapies. Cindy, would you comment on sort of that, if you will, great wall between the first and second stages of therapy and what would historically been called third-line therapy?
Yeah, I mean, I would agree with you, Roger. These, you hate to see these numbers as you're treating patients, but they're the reality. And I mean, multiple studies have shown that patients hear what, they're listening to what you're saying about the dietary and behavior modifications. And even if they do work, they really don't, they're looking for something more because they're not satisfied. And medications, they're tired of medications, really, and they have a laundry list of other medications, the interactions, the cost. I love third-line therapy. I do a lot of the third-line therapy, but there are some roadblocks to patients accepting the third-line therapies as they currently are. And I'm very excited that we have another option that actually, as we'll mention a little later in the slides, can be plugged in a lot earlier in this paradigm.
Thank you, Cindy. Next slide, please. So obviously, there are, if you will, factors, I guess, that we all have seen in all of our practices about what influences people to go to watchful waiting and what might pull them out of that group for purposes of perhaps definitive therapy. And I think as we increasingly enter an informationally based age and information technology and is really causing and allowing people to be much more free from tethering from a variety of electronic devices. What we're seeing is people really are asking for ease of use that adds to this whole feeling of fulfillment and, if you will, peace of mind by controlling their symptoms, but also allowing them to perhaps modify their therapy based upon their needs. And we historically have sort of had pro rata, if you will, treatment paradigms for patients. And in reality, as Cindy has done excellent work in, as we look at the natural history of overactive bladder, sometimes people need more intervention, sometimes they need less, and perhaps the ability to self-tailor therapy is really where we need to be going in terms of meeting what patients ask for. Thoughts, Cindy?
Yeah, I would agree with that. More and more patients are wanting, a single event to help with their incontinence. They want to be involved in their therapy. And this was, the attraction to this procedure for me is patients really they understand, they've heard me say it multiple times, that this is a chronic condition. Urgency incontinence is not something that's going to go away. So they have to be engaged. It's like a diabetic being engaged with their glucose monitoring and tweaking their therapy. They also really want to have freedom to, have no limitations in what they do. And definitely they would like therapy that doesn't wear off or all of a sudden doesn't seem to work anymore. And, we don't know why that happens with therapy, but it seems that's a common theme that patients are very frustrated about.
Thank you, Cindy. Next slide, please. So recently, this new therapy, which we're going to discuss in complete form in just a few moments in terms of what's involved, which is now known as Revi, which is the marketing name for essentially a very unique implantable tibial system, was approved by the U.S. Food and Drug Administration in mid-August of this year. And the verbiage that you see on the screen is the actual statement from the FDA. And there's a couple of interesting aspects to this. One, the indication statement, obviously, the clinical trial was designed for wet patients. And so the FDA has indicated that this intervention should be used for the treatment of patients with symptoms of urinary incontinence, urgency incontinence alone, or in combination with urinary urgency, because the data, as you'll see, really demonstrates effect on both of those elements of the complex of urge incontinence. But they added some additional verbiage, which is quite interesting. And again, this is a direct verbatim from the FDA indication statement, if you will, amplification. It basically says that treating clinicians should follow clinical guidelines as applicable, obviously, and should use their discretion to determine whether the patient should fail or not tolerate more conservative treatments before using the Revi system. And so this is a very interesting modification or alteration of prior use statements in this field. And Cindy, I'd be interested in your thoughts about our sort of hierarchical approach to urge incontinence historically, and how this particular indication statement may affect that, or may be used as a modality in the interpretation of that hierarchical algorithm that we use for urge incontinence.
Yeah, no, I was very pleased to see this statement. It really does provide physicians, more freedom in offering therapy. As you know, we're trying to figure out subtypes of patients with this problem, and it doesn't make sense to say, oh, everyone has to start out with medication, then move to this therapy and move to that therapy. So I was thrilled to see this, and that we could potentially intervene sooner and have an option, a different option for patients earlier. So I couldn't be more pleased.
Next slide, please. So We've been talking about the system, and so let's dig deep down into and dive deep down rather into what the system is. And so there are essentially, if you will, three components of this system. Of course, the patient and the practitioner are major components. We assume they're there. So these are the three additional components that are really critical for this device and this intervention. On the left-hand aspect of the slide, you can actually see the actual implant. And the silhouette of the device is very small. As you can see, the entire length of the device is only 3 centimeters. It is implanted in the distal tibial region, just above the medial malleolus of the leg. That is the implant itself. The implant receives its power externally, though there is no internal battery. There is simply a receiver and essentially a transmitter within that device that allows the transmission of energy from the external wearable, which we'll talk about in a second, and the device itself. Cindy, we're going to talk a lot about implantation, but the device itself, just your thoughts about ease of implantation of this particular device, and your thoughts about how it fits in the sort of the global world of a woman's ankle.
Yeah, I was delighted to see it's light and small. Secure, and surprisingly, it is quite deep, sits pretty deep down. So patients, they're worried if they could feel it, they can't feel it. Not when you'll see where the neurovascular bundle is. It's well away from the skin edge. So patients are very delighted to know that this seat's really deep. They're never going to feel it.
The second part of the device is the central component of the slide, which is the wearable, which allows the patient actually to apply the energy that is received by the device through essentially Bluetooth RF transmission. And essentially what happens is the external wearable, which can be worn at patient discretion, and for the purposes of the clinical trial was worn twice a day for 30 minutes, and we had greater than 90% compliance with that. But the external wearable is actually where the power source is for the device and feeds into the implantable that Cindy just commented on, and we'll talk more about in a second. And finally, the last element is the clinician programmer. This is a programmer that can be used either by the implanting practitioner or that person's delegate. If, for instance, if you use nurse practitioners or nurse extenders in your clinic, this device, this programmer is very straightforward and, if you will, facile for activation and use, and communicates again with the wearable device to essentially help the wearable device and the internal implant perform as needed for the management of the condition. Next slide. So let's delve down into these three components. First is the implant itself. We've already talked about the device itself. As I mentioned, it has the electrode array, which is demonstrated, as you can see on the left, by the two silver coated aspects, which are the actual electrode sites. And it has a receiver and a pulse generator. And of course, the receiver receives the energy, and then the pulse generator generates the pulse, which is then felt by the electrode array, excuse me. We've already talked about the aspect of external power, so there's no internal battery, so therefore no need for battery replacement. The FDA has currently said the device is safe for at least 10 years in terms of its internal indwell time. There is no risk of leads fracturing. It is embedded in a silicone carrier, which is that shelving that you can see on the left with the 4, if you will, needle sites for purposes of co-location of the device over the fascia with suture. And that allows, again, the ability to ensure that the device stays in place once it's sutured in. And indeed, there have been no migrations with this device in our clinical experience. And it is recently received MRI conditionality. And as you can see, patients can be scanned anywhere in the body, including the leg. And that's a really substantial attribute in the neuromodulation market, because again, our use of MRI now is such that we have to have devices that are compatible with the 1.5 and 3 Tesla machines that are commonly used in clinical practice. Next slide, please. The other two elements, as we discussed, and Cindy, I'd like Cindy just to comment on her concepts of patient reaction to the wearable, which is very light, as you can see, 7.8 ounces. What are your thoughts about the wearable, Cindy, and how patients integrate that into their daily life?
Yeah, no, I mean, it looks bulky, but it is very lightweight. I mean, it weighs less than a great running shoe, top line running shoe. Maybe not the best running shoe, but but a good one. So the patients can walk around and really had no problem at all with the 30 minutes of stimulation while they're doing their work, preparing breakfast, doing things. So no complaints.
And then the final, and then the final aspect is the Revi clinician programmer, which we already discussed, which again allows the, if you will, the programming, initial programming and setup, and then also captures patient adherence and therapy parameters, which obviously as we move forward now is much more closely approximating what we've become habituated to from the work that our cardiology colleagues do for implantable cardiac devices, where they can actually be remotely assessed for a variety of parameters, and in the case of cardiac devices, the device firing and whatnot. For this allows the clinician to determine the patient's interaction with the device and how often they're using it and how they're using it. And one point we'd like to both make during this presentation is, because of the patient centricity of this device, patients are using this device in our in the extended blue wind data, in the 2 and 3 year data, really at very interesting parameters and levels, not surprisingly. So there is a retained benefit from stimulation, and for the purpose of the trial, it was twice a day, but we're certainly seeing patients use it less with time and integration with the therapy. Next slide. And finally, there is an app. The app essentially is not only a device app that allows the device to be managed, but it also allows patient support and integration, as well as latest education. And this is really a top of the line app. And I think as you get familiar with it, you'll find that it's very facile for patients, but also very educational from the standpoint of integrating the patient in their condition, and also options for their condition and appropriate management. Next slide. So we'd like to spend the next third of the discussion talking about the clinical trial. Cindy was a very significant contributor at her institution as an implanter, and as an expert implanter, and her surgical expertise will comment on in several of the next slides. It was a multinational study. As you can see, it was in both Europe as well as the US and UK. The primary endpoint was urge incontinence reduction at 6 months, with responders being defined as a standard regulatory definition, which is at least a 50% reduction in urge incontinent episodes. More on that in a second. And also from the standpoint of regulatory assessment, the incidence of device adverse events, which is obviously a critical aspect of any new device, as the FDA rightfully wants to make sure we're putting devices in safely. The temporal timeline that is horizontally presented actually presents the actual device, if you will, milestones. The device is implanted. It is activated approximately a month after implantation, and more on that, and I'll have Cindy comment on that when we actually look at the films of the implant. There were 1, 3, 6, 9, and 12-month follow-ups with a variety of endpoints at those follow-ups. And as I mentioned, there is long-term data being generated both at 24 and now 36 months. Next slide. So this is the consort diagram. Again, Cindy, we had 151 women in this trial. Comment a little bit about, if you would, the magnitude of a mean of 4.8 urge incontinence episodes on a daily basis.
You know, from the get-go, I was thrilled that this study really only addressed what I think is the most challenging group of patients, which are the wet women, urge incontinence. And I'm very delighted to see that the mean was 4.8 per day. That's many of the third line therapies that we've done studies on. That was the average 5 UUI episodes per day. So it's in line with even the worst of the worst of patients. And so I was delighted to see that it was such a severe group that were enrolled.
Thank you, Cindy. The disposition, the consort diagram sort of turned on its side, if you will, is demonstrated there. A couple points. 151 patients actually underwent implant, but as you can see, that's greater than a 50% capture rate from the screening population of 282, which is fairly dramatic for an urge incontinence population, and demonstrates the integrity of the actual clinical trial design. 151 patients were activated, and as you can see, 140 patients were reported at 12 months. You can see the reasons for dropout, and not the least of which were, again, issues with compliance and patients who had other concerns. We had one explantation during the trial. That was a patient who had an unanticipated cardiac event that required explantation because at that time it was not understood the device's interaction with cardiac devices. That is now much better defined from a regulatory standpoint and a safety standpoint. So that particular concern has been resolved. So again, the data you'll see is on 140 patients at 12 months. Next slide. So this was an intent to treat population. At 12 months, there were no serious adverse events either related to the device or the procedure. Essentially, all the procedure and device-related adverse events were anticipated and categorized by both the investigators as well as the DSMB and Clinical Events Committee as being either mild or moderate in nature. Overall, 10% of patients had some procedure or wound-related adverse events. We had no wound infections resulting in explantation. We also had 6 patients who had device-related adverse events, 4%, and that was mainly related to issues related to stimulation changes. As we all know, there are some patients who experience the uncomfortable stimulation thresholds, and those simply need to be modified. Next slide. Here's the efficacy data, and Cindy, again, from the standpoint, not surprisingly, there are substantial reductions at both 6 and 12 months in the ITT analysis in terms of urge incontinence reduction. Just a point, you've done a lot of health-related quality of life research. Your thoughts about the 10-point reduction or greater and how that sort of reflects what we're seeing objectively in clinical diaries?
Yeah, no, I mean, it was nice to see that, 80%, over 80% at 12 months had a significant improvement in their quality of life. We also included improvement in urgency episodes. And then this is the big category too, that large volume leakage. That's an important thing in a lot of patients' quality of life. So these are right in line with very good studies, but this is really high percentage meeting all these secondary endpoints.
Yeah, and to Cindy's point, the large volume urge incontinence reduction is obviously it was a secondary endpoint and was sort of evaluated for, but the dramatic reduction in that really implies if you will, the therapeutic, if you will, magnitude of the tibial nerve and its ability, despite being a very distal peripheral nerve, to have substantial impact on a very specific co-location within the spinal cord. Next slide. Next slide, please. I think we have a slide block here. While we're waiting for slides, the reductions, interestingly enough, as you'll see in the frequency histogram very soon, will be quite demonstrative. We'll show you 1, 3, 6, 9, and 12-month data. And the take-home message in this build histogram.
One slide back.
Yeah, there we go. The take home here, and Cindy, I'd like you to comment on this, is if you look at the blue hued bars, which are the top 2 in all the columns, I think you can clearly see visually and also numerically an amplification both in the darker hue and the lighter hue. And the lighter hue is a particularly interesting aspect to the contribution of overall effectiveness, because that's the patients who are 75% or more reduced. And Cindy, you've done a lot of this sort of, if you will, computational analysis on symptomatic improvement, and your thoughts on this substantial reduction in incontinence associated with neuromodulation, this type of substantial reduction, excuse me.
I think what's impressive is that this graphic really depicts the benefit of having a therapy that you can individualize the stimulation parameters based on their symptoms throughout that year. And as I mentioned before, we know this is a chronic condition that kind of waxes and wanes, and it's not something that's always going to be good. But responders, as you can see, responders continue to be responders. And I think, as you mentioned, that group that the lighter hues, 75% reduction in UUI episodes, that percentage of patients went from 52% to 67%. So, they would just kept getting more, people started getting drier as the year came, as the year ended. I also see that it's another reflection of that tweaking or fine-tuning the individual patient is the group that in the orange that started out at 1 month. There were a lot of not what we would consider non-responders, and 50% of them ended up in the responder category by 12 months. Again, just going and tweaking their stimulation parameters. This is one of the things that I've always, when I started working with BlueN, I said, you have got to figure out predetermined algorithms to troubleshoot patient symptoms, because that is going to be key. And, it really seems like it's working. And we do know that patients do need that individual approach to their stimulation.
And as Cindy said, what we all feel, the investigators, is that this is an amplification and representation of what we can accomplish with patient interaction with their device and self-regulation. Really a very impressive change in terms of from the baseline symptoms. Next slide. And of course, what does this connote to? Well, it connotes to very high satisfaction rates. And we had a 50% continence continence level, in the last 3 consecutive dry days on avoiding diarrhea. There's a lot of questions about, do patients comply? And again, because of FDA requirements, it was a rigid requirement that the patients utilize the device twice daily for 30 minutes. And as you can see, 92% of patients were compliant with that treatment regimen, meaning 9 out of 10 days patients did it twice a day for 30 minutes. So that's also very significantly compliant. But also, as I said, we're seeing now in the follow-on studies that patients modify this treatment and to a much more refined intervention and focused intervention based upon their level of symptoms. Next slide. So talk a little bit about the patient selection, and we'll sort of give you some summaries of that, as well as therapy delivery. Next slide. So obviously this is an urge predominant patient. Obviously, for the purposes of the clinical trial, we wanted to make sure that patients didn't have significant pelvic organ prolapse or active urinary tract infections. Want to make sure that we're picking the correct patient for an implant. And this really is not surprising, is really all of us, when we do surgical implants, don't want patients with, for instance, suppurating ulcers at some aspect of their anatomy because of the concern regarding embolic infection. So again, you want to have a patient who's as optimized as possible for an implant. You want to make sure the patient has reasonable sensory function and doesn't have significant peripheral neuropathy. There is a constraint with the device from the standpoint of leg circumference. The leg does need to be between 20 and 30 centimeters for adequate communication between the wearable and the actual implant. Therefore, we recommend a consideration of a BMI limitation of less than 50. But as we all know, there are some very large patients from a BMI standpoint who have small ankles. So again, the anthropomorphic issues really are individual and need to be defined, obviously, at the time of consideration for that individual. And obviously, the patients need to be interactive with their therapy. And I think we're all aware of some recent data that suggests that neuromodulation may have some effect in patients who aren't cognitively intact. I have real concerns about that. I think cognitive intactness is critical for neuromodulation to be beneficial for patients. Cindy, what are your thoughts about that?
I would agree. It's attractive therapy for patients who may not be, but they do need to be engaged with their therapy and remember to put the ankle the wearable on and use it and optimize this therapy. So I would agree, it's not for everybody, but
Next
for
slide.
a lot.
Thank you, Cindy. Next slide. So who are the patients that might be reasonable? And Cindy, you've certainly had to make some decisions regarding this. Why don't you, if you would, just sort of tell me or tell us what, looking at the points made on this slide, what really is salient to you from the standpoint of your prior decision-making regarding patients for this implant.
Right. I mean, I really hit home on the active patient. All of them, I ask them all the time, you're doing your sports. Do you have any weakness? Do you have any problems with movement of that ankle? None of the above. So I really think it's great for the active patient, whether they're young or old. Definitely the younger patient who really wants more durable therapy. I have a 19-year-old on the schedule for next month, who's been battling her urge incontinence for many years. And I also agree that older individuals, I have more and more active community dwelling older patients who really, think this is a great idea, even though they could go under other anesthesia, but they really think this is a great idea. So, and then of course the patients where other therapies aren't working or not good candidates, like the Botox patients or PTNS, if they've responded, they really want to have some implantable device that they don't have to keep coming back to the office to get their subcuticular stimulation. They're very happy to know that there's an implantable. So I really love, or patients do love, the minimally invasiveness of this procedure.
And to Cindy's point, obviously also those patients who have concerns regarding manipulation of their back because of a variety of concerns, not the least of which is fibromyalgia, and also patients who perhaps are fatiguing of Botox therapy or are concerned about the risk of retention. Those are also patients who obviously exist in all of our practices, and those are concerns that we all deal with clinically when we have these discussions with patients about perhaps next levels of therapy. Next slide. So this is the actual landmark slide, if you will. We call it the 252 method. Number one is the peak, if you will, the Matterhorn of the medial malleolus, the highest point of the medial malleolus. And as you can see, you measure 2 centimeters proximal from that. I measure an additional 5 centimeters from that, and you make 2 lines, and those 2 lines essentially give you, if you will, the area of focused intent for the neurovascular bundle. It's very important to realize that the, if you will, the inferior or posterior edge of the tibia is a great landmark, geographic landmark for identifying, if you will, the sweet spot. And again, you go 2 centimeters posterior to that edge. And Cindy, I've watched you do this, and you're really an expert at this. And any other points about this particular landmark issue?
I am a perfectionist, and initially at the pre-op area, I wanted ultrasound there, and I marked it, and then I would ultrasound over to make sure my marking was where that neurovascular bundle was. And it was. This is a great method, this 252. So now I don't use ultrasound anymore, and I am convinced this is a great method.
Next slide, please. So these are a couple of intraoperative photos, and again, this is a subfascial placement, and more on that is when we talk about the actual procedural coding. Subfascial placement does involve more physician work. It can be done under local anesthesia. Cindy has tremendous experience with this. I think she's done it both under local and local with sedation. It's certainly up to you what works best in your environment, but clearly a small skin incision created, as Cindy mentioned, with blunt dissection down to the level of the fascia. You can see a very nice on the upper right demonstration of the fascia overlying the neurovascular bundle. You can actually see the actual sort of white, if you will, or yellow-white discoloration in the central part of the slide at the tip of the Metzenboms, which indicates the neurovascular bundle. And in the lower aspect is the actual appropriate localization of the device in the distal ankle for purposes of the actual stimulation. And again, the device is fixated. There are 4 fixation points, and we do recommend utilizing suture fixation for that. Interestingly, at the time of insertion, and Cindy can talk about this, but there is intraoperative testing utilizing the external wearable, so you can actually determine your proximity to the nerve, which obviously is critical, as we do think that the proximity to the nerve is really part of the messaging of the sweet spot of efficacy that we see with this particular device. Cindy, any sort of comments about that localization and the use of intraoperative stimulation to assist that?
Oh, I think it's vital. And as Roger said, I started to do a little bit of local and IV sedation, but I would, wake them up easily and then ask them. I really do. I like confirmation in the OR that it is comfortable and they're feeling it in the right spot. And then I feel great about the technical part of the procedure. So I think it's a great thing that we could do that intraoperatively. Now I just do it under local anesthesia, and patients surprisingly tolerate it very, very well. And, the leg seems intimidating to work, just like when those who do, sacral neuroma, the back seemed intimidating to work at. Just the training that Blue Wind provides really makes it then very comfortable. And then this is the
I'm sorry, go ahead.
Yeah.
No, please go ahead.
No, I'm sorry. No, this is.
Yeah, please comment, because I think your elaboration of this diagram is going to be very helpful for our implanting surgeons.
Right. Well, the sweet spot is that heel and sole of foot, and pretty much when it's right there on the neurovascular bundle, it's always there, 100%. Thumbs up from from anesthesia, going, yep, that's where they feel it, and so and then it being comfortable. It's always comfortable if it's in the right spot.
Cindy, when you implanted, did you actually show the patients this diagram and actually ask them where they were feeling?
Yes, we show the diagram, and then they kind of point to the area, and making sure that it is the same area we're talking about. Yes.
Excellent. Next slide. This is a procedural video. Go ahead and start the video if you would. So this is just the injection of the local. Cindy, a comment about the superficial nature of the injection?
Yeah, you just don't want to get subfascial, and then the sensory will be gone. But as you could see, I just used Wheatlanders to really spread. Yeah, that's a nice way to sort of spread that fat. Used very little, if any, coagulation is necessary because it's just fat. Sharp dissection of the fascia, and then the neurovascular bundle being right there. Extending, and there's a neurovascular bundle as it's being demonstrated. The fascia is just extended both directions. We do a little bit of irrigation of that area. And then that electrode is then placed down. And so the electrode is then on top of the neurovascular bundle. Sometimes we tuck both ends underneath the fascia on the top and bottom. You, of course, don't want to grasp the electrodes. Plenty of silicone on either side to handle that electrode, and it's placed nicely along the nerve. And here's how we're turning it over, sliding it under the fascia.
Comment about the polarities, if you would, of the electrode.
Right. So you'd want the larger end more toward the head, and the smaller end toward the feet. We initially then attach the two sides of the electrode to the sides of the fascia, so the edges of the fascia, and now we'll then test it for the stimulation. Okay.
We went back. Okay, yeah. We'll just move forward. So that basically showed you the essentially presentation. The management of these patients 4 weeks post-implant. obviously, is they are sent home. The wound is closed either with interrupted external permanent monofilaments, or you can use subcuticular closure. The most important thing, obviously, is an airtight closure. The patients are sent home with a wound dressing and a compressive dressing as well. The patients are asked to elevate their legs, but they're not at all bed bound. They can be active. They just don't want to be standing for extended periods of time in that first week or so. And then at 4 weeks, the patient is activated and with the representative utilizing the clinical programmer, as you've seen. Their device actually has 2 preset treatment programs that the patients are sent home with, and they utilize their wearable to deliver the therapy, again, when it's at their convenience. Again, the recommendation off therapy, off clinical trial is 30 to 60 minutes at the patient's convenience. But as I said, we're seeing some really interesting signals about length of delivery and also numbers of delivery. And there is a tendency, even in some patients, long term to not require daily therapy. We're trying to crystallize that data right now in our long-term follow-up. But again, it gets to this whole concept of optimization and customization to the patient's needs. Cindy, in your experience when you've implanted the device, first and foremost, in that first 4 weeks after implantation, any tricks or issues that you've identified that have really helped the management of your patients postoperatively in terms of care of their leg immediately post-implant?
Yeah, I mean, I agree with they don't mind to elevate their leg periodically for the first 72 hours. Some have also put ice on it. I think they've not had to use any narcotics, not even Tylenol. So I think if you can decrease swelling in the area, they have then less pain. And then of course, any issues with complications. So they're happy to sort of be okay with elevating it if as needed, but walking around fine, taking steps fine, doing regular activity very quickly after the implant.
Cindy, and I believe you've had some very active post-operative patients, right? I mean, I think you've had some athletes as well, or runners,
right.
or runners.
Oh yeah, I definitely a horseback rider and a hiker and very active patients. And as I mentioned, I'm very happy when they come back, and I'm always asking any range of motion problems, any soreness, nothing. So again, I do like how deep the electrode sits. It is gone. It's away from the skin area, and just really like how the placement is done.
Okay, next slide, please. So for the last bit of the actual didactic presentation, before we go into the questions in the last few moments of this hour, we just wanted to give a brief highlight of current reimbursement and where reimbursement is going for this therapy. As you know, this is a totally new procedure, and so there is a set of criteria that are utilized for totally new types of devices. So next slide. And Blue Wind, in conjunction with the AMA CPT committee, has developed a tracking code level 3 code, which is the 0817 code. You can see the descriptor, and essentially it's a implantation of electrode, array or leadless, with or without pulse generator or receiver, including analysis, programming, and image guiding when performed on the posterior nerve. And this particular code is for subfascial placement. So 817 is, again, a code that has a unique work time frame associated with it, and that's associated with a subfascial payment. Medicare's proposed outpatient hospital in reimbursement for your site of service is as noted. And there's a very active program called the Revi Access Program, where you or your clinical staff can actually contact this program to get assistance in helping getting a prior authorization for facilitation of access to this particular therapy. And next slide. And in relationship to the code itself, it is a category 3 code, otherwise known as a tracking code. Tracking codes are utilized Generally, for new devices, and many of you know about this from experience with other devices in the urologic armamentarium, and basically these codes are utilized to demonstrate how the device is utilized once it's approved by the FDA, and also for clinical tracking over the first year or so after FDA approval. But essentially, the work associated with this device, and this is important as an appropriate context for the payment request. Basically, you should know that it has a 40 to 60 minute intra-service time. And again, remember, intra-service time includes patient preparation, patient counseling at the time of the day of the surgery, preparation, actually the procedure itself, and then the application of the dressing and preparing the patient to leave the center. So it is a 40 to 60 minute intra-service time, and that is what the AMA has determined to be the similarity between this code and a Category 1 code with that length of time. And as we all know, length of time is one of the great indicators of physician work. So if you'll remember that is 40 to 60 minutes, and basically the CPT 817 code is comparable to whatever code you choose that has that particular length of stay or work degree of work associated with it, for which is charged X amount of money. Okay, that will conclude. I'm sorry, next slide. Apologies. So to conclude, and again, I'd like Cindy probably to opine on these four particular aspects, but my big take home here is the patient centricity of the device and the coding and payment establishment that have been developed. Cindy, just a little bit about the invasiveness of the device, et cetera.
No, it is nice that it's a very minimally invasive. Patients are really searching for something that's not impacting their life for very long, and this doesn't. It's a quick implant and a quick healing period. Very, they don't like to use pain medication. They don't need to. And one stop, they're not having to come back to the office and for decreased efficacy of, getting another treatment or another treatment. So that's great. And I love the predictability of placement. I like to leave the OR knowing that I've done a good job. And I do like that you get that intraoperative feedback. It's going to be comfortable. I'm happy with the placement. It's secure. I've been able to attach it to the fascia. It's not going to move. I've covered it over nicely, done a nice dressing, so I don't like any complications. So I really have been happy with this placement, with this device.
Next slide, please. Well, that concludes our actual formulaic component for this presentation. We do have some questions, and there's been a very active question lobby, and Cindy and I will try to address these in the next 5 to 7 minutes before we wind up shop. Cindy, there was a question from the floor about experience with lymphedema at the implant site, and perhaps goes, no goes, how you manage that, and what your thoughts are about lymphedema at the implant site. Or proposed implant site, excuse me.
Oh, at the pros, yeah. I think that that's a concern, definitely a concern. And there is already that 20 to 30 centimeter sort of restriction just from the wearable. But I would say that a patient who has significant lymphedema, maybe not the greatest patient, but if it's a little bit of swelling, those patients I've suggested they do wear a compression hose afterwards so that incision heals nicely. But I would say probably not the first person to do the procedure on, and maybe if we get more information about this sort of group. What would you say, Roger?
No, I totally agree, Cindy. I think that, what we use for the clinical trials is probably a good go by. You don't probably want to go more than 2+ or more pitting edema or edema. So obviously people are variable with that. And obviously some of that relates again to what Cindy said, the measurements and the importance of that circumference. So I think that's a good go by. There's another question about non-obstructive retention and whether or not the device is indicated for that. The device has not been studied in non-obstructive retention. I know that exists for other types of neuromodulation. Obviously, we're at the very beginning of this therapy, so there's a lot of new studies that will be evaluated for future indications. And then there's another question about data on efficacy for patients who are less compliant with daily stim. Well, I would like to say that we know that, again, from the purposes of the clinical trial, the patients sort of agreed to be very rigorous about their therapeutic delivery. In other words, 30 minutes a day, twice a day. And again, you saw the 9 out of 10 compliance with that. Again, as I said, what we're seeing in the longitudinal 2- and 3-year data is that patients modify this. And one of the great things about perhaps the clinical device and the app is that we're going to be able to monitor, with their permission, patient use, and be able to see how patients individually treat themselves. And again, Cindy's work on the sort of this fluctuations of OAB across time is seminal in terms of understanding that, you know, sometimes you need more therapy, sometimes you need less therapy. And if the patient who experiences those symptoms is the one driving it, it really, I think, adds a lot to that. So again, interesting enough, less compliant is a term that probably is not very applicable to this group, because I think, again, the patients will be compliant as it pertains to their needs. Cindy, if there's a question about who programs the system, should I do it, or can I have a nurse practitioner do it? How do you do it in your office?
Well, you know, in other neuromodulation systems, I do it, but I think the good thing about Blue Wind is that they plan to have a very active field clinical group. So they will be accessible, and then a lot of this eventually will be call in and you know, patient app, and then the clinical field specialist can do it, not even being in your office. So that's eventually how things will go. So at the beginning, you probably can depend on the clinical field specialist being there, doing all the programming. But if you want to learn, it's like Roger said, pretty user-friendly clinical programmer.
Cindy, we've already sort of talked about this, but in your experience, how quickly could your patients get back to sort of baseline activity after implant?
Oh, they're getting back to it within a week. I'm seeing them after 2 weeks, because I did do the permanent interrupted sutures, and I'd see them in 2 weeks' time, but they were definitely within a few days doing fine, and in a week, you know, really not missing a beat and what they would like to be doing. Now, they didn't go run their marathons yet, but they were doing basic activities of daily living and doing their things pretty quickly.
Just a couple questions about the clinical study. Oldest patient was 81, youngest patient was 24. Cindy already mentioned that she's got a 19-year-old teed up. So obviously, this has been studied now in a wide range of people, and we're gathering more and more data as more and more implants are being done. So that will continue updating you on that as we go. There's been some questions about the actual programming and the parameters of the programming, and the initial, if you will, baseline parameters or frequency are frequency of 14 hertz and a pulse width of 210 microseconds. So again, that's sort of the baseline data, baseline parameters, if you will, that then can be altered later in therapy. And all of those parameters can be changed with the clinician programmer. So you have substantial mobility across the various therapeutic platforms in terms of the programs to change as you see fit. There's another question about, is there diminished efficacy in patients with diabetes mellitus and peripheral neuropathy? Good question. Don't know. I mean, we didn't study patients specifically for that. Obviously, nerve integrity is really critical for current transmission. So, you know, obviously that's another group that needs an assessment. I will say that peripheral neuromodulation is one of the areas that is being evaluated currently for perhaps management of peripheral neuropathic pain. So that's a whole different discussion. So, and finally, there's a question about relative contraindication with pacemakers similar to PTNS. There is no contraindication. There is a strong advice to discuss with the patient's cardiologists the ability of the device to be implanted in a patient who has an extant or existing cardiac implant, but there's no contraindication to that per se. Cindy, we've got about 90 seconds here. Just your final thoughts on things and your takeaway from where we're going and your perceptions of this therapy, please.
Yeah. I think it's a great therapy to offer patients. And now with it being FDA approved, that you don't have to be going down this algorithm of fail this, fail this, fail this. It's going to be introduced a lot earlier for me. I do feel like, not everybody responds to all one treatment. So I will tailor who I offer this to, but I think it really is a very wide group of patients who this therapy will benefit. And so I'm thrilled to be able to have this option.
Thank you, Cindy. Back to you, Dan, to close out things.
Okay. First off, I don't know that I've ever listened to two people talk for an hour and not have anything to add. That was just a terrific overview. And I'm not going to debase it at all by doing anything else here other than to tell you that you're going to get a short survey for those of you on the line immediately after this. If you want to know more, we'd love to hear from you. But just a terrific job of laying this out in terms of why we truly believe we're going to have a profound impact on patients who suffer from the affliction of urinary urge incontinence. And thank you so much, Cindy and Roger. And thanks to everybody on the line for joining us.
Yeah, thank you.
Have a good evening, everyone.